There are three hormones produced by the adrenal glands in the female. In the male, it's only two. In the female, they produce the salt, sugar, and sex hormones. In the male, only the salt and sugar hormones. Salt hormone is referring to aldosterone, obviously. The sugar hormone is referring to cortisol. So let's review how it works. The adrenal gland, as well as any other gland, is affected or controlled by the pituitary gland, correct? So therefore, some pituitary disorders may cause adrenal disorders as well, right? But we'll specify that. So there are two parts to the adrenal gland. So adrenal glands sit on top of each kidney, correct? So there's a medulla and a cortex. So the medulla produces your catecholamines. Catecholamines are your emergency hormones, which are adrenaline, norepinephrine, called catecholamines. Now there's a cortex part, which is the outer part of the adrenal gland. This one is where your aldosterone and your cortisol comes from. You have to specify because a tumor can grow either from the medulla or the cortex, which will change your disorder. Let's start with glucocorticoids. So this is your cortisol. This is an emergency hormone secreted during times of stress. So that's why your uniforms shrink during exams or as you move through the semester. Okay? Because what will your sugar levels be during stressful, exams, stressful or higher? And what will your body do with the excess sugar? Convert it into fat. Okay, so that's how our body works. And the mineralocorticoid, this is the aldosterone. So aldosterone, you learned under renin-angiotensin-aldosterone system. So this is responsible for sodium and water reabsorption at the kidneys in times of, what were the triggers again? There were 5 triggers for aldosterone release. Low blood pressure, low blood volume, low blood sugar, low sodium, and low oxygen. Okay. And adrenal hormones, of course, in the female, without these, then the female patients will look like a man. Okay. So of course, this is not life-threatening, but is it important to the patient? Yes. Do you want to look like a man, Miss Mariam? No.
So the transgender, right? If
Let's not talk about that. That's a separate issue. So I'll just yes, but yes, to answer your question quickly, yes. If you manipulate your hormones, then it will change how you look. Okay. Are you planning to transition?
no.
Okay. Yes.
I know somebody, she's a woman, but she have a beard.
Okay, we'll talk about that. Okay, so that's one of the symptoms in one of these disorders. Okay, for the androgens in the male, of course, that comes from the testicles. So we're talking about adrenal problems, so there will not be any sexual characteristic changes in the male patient. Okay. Let's do this first. This is the quickest. Pheochromocytoma. It's a oma, so therefore this is a tumor. A tumor where? This tumor grows in the adrenal medulla. What were the hormones secreted by the adrenal medulla again? Epinephrine and norepinephrine. So if you have a catecholamine producing tumor in the adrenal medulla, and this tumor is big, by the way. Where are the adrenal glands again? Okay, and then where do you usually where can you reach the kidney? Can you reach the kidney from the front or from the back? From the back. However, these tumors are so big that they are palpable from the abdomen. So if they grow in one, or if you're really unlucky, grows on both adrenal glands, so you'll have one or two palpable tumors, okay, in the abdomen. on the sides, okay, where your kidneys are. Risk factors, it's rare. We don't know what causes it. Just luck, I guess. Manifestations will be basically what happens if your epinephrine or norepinephrine levels are really high. What will you look like? You look like a chicken. Okay, so you will be doing this. You're very nervous, your heart rate's always fast, your blood pressure's so high, you're sweating all the time. Okay, it's like you're in fight or flight constantly. Now, what happens to your what could possibly go wrong? Your blood pressure is so high. Can you have a stroke? Can you have heart disease? Could you die? Yes. Okay. So the manifestations here are manifestations basically of severe hypertension, severe tachycardia, which are tremors, headache, flushing, anxiety. There will also be hyperglycemia because remember, stress hormones are released. So this will cause the release of glucagon as well, right? So glucagon's released, it will break down sugar. Okay, so it will increase sugar levels. Until this patient, because the only treatment here is surgical removal of the tumor and also of the adrenal gland, because it's in the medulla, so you can't really, you know what I mean? It's in the inner part of the adrenal gland, so you can't like punch a hole and make your adrenal gland look like a donut. It doesn't work like that. So you have to remove the entire gland. Until then, the patient will suffer from attacks, and again, just severe hypertension occurs, and then the patient again has these manifestations, all from extreme tachycardia and extreme hypertension. Because the tumors are quite big, the patient may have abdominal symptoms as well. Okay, they could have vomiting, abdominal pain, and whatever you do, do not palpate the tumor, because if you press on the tumor, if you squeeze it, then it will cause release of more catecholamines and then may cause a stroke. So how do we know? Then there are 5 H's, all again manifestations of severe tachycardia, severe hypertension. So there's hypertension, headache, hyperhidrosis, meaning sweating, hypermetabolism, and hyperglycemia. And we have to get a CAT scan or an MRI to see the tumor. Once we have them, then I won't read all the possible manifestations, okay? But keep in mind that this, until the patient undergoes surgery, there could be complications which will exacerbate the condition. Let's say coffee, smoking, physical stress will could lead to death, right? Because these factors here will increase blood pressure, correct? So that will basically exacerbate the problem, right? So when you have this condition, can you still use meth? Unique? Can you continue with meth? Yes or no?
I don't know.
Okay, you have
No.
to stop meth for a while. Okay, and that includes also over-the-counter cough or cold medicine because they contain phenylephrine, right? Which is a sympathomimetic. So those drugs also cause hypertension. So this obviously they will cause complications. Look at the patient's blood pressure. Okay, so this patient's blood pressure will be over 200 systolic and then over 100 diastolic. And imaging studies again will confirm the presence of the tumor. Let's go to management. Until you can undergo surgery, we'll have to give you lots and lots of blood pressure medicines. So we're dealing with giving you beta blockers, calcium channel blockers, antihypertensives, no ACEIs, ARBs, okay, just to control your blood pressure. And you will be monitored on a neuro or telemetry unit so in case you get a stroke. So there's really no drug for the tumor. So the drugs mentioned here are all to control your symptoms, lower your heart rate, lower your blood pressure. You can also use diuretics as well. So those are the medicines I already mentioned. And let's go now to surgery. So the treatment for pheochromocytoma is to remove the tumor. Unfortunately, again, we can't peel the tumor off of the adrenal medulla. So the adrenal gland will have to be removed at the same time. The outcome will be, and management and outcome will depend. How many tumors are we talking about? If it's one adrenal gland, it's better, okay, because that means you still have one more gland. Okay, you still have one more. So what are the hormones again being produced by the adrenal gland? So we have the epinephrine or epinephrine from the medulla, and then the cortex has the aldosterone and cortisol, right? Plus in the female, the sex hormones. Now, if we remove one, the other will compensate, correct? However, if we remove one, does the other one compensate right away? Meaning, let's say you're you're a couple and then one of the partners loses their job. Will your income be enough? No, right? So you'll have to suffer for a while, right? Until the wife uh or the husband earns more, right? So that we can, yeah, so same exact concept here. So the remaining gland will take time in order to increase production to supply the needs of the body, correct? Until then, the patient will require supplements, correct? Meaning the patient will have to take steroid hormones for a while, okay? Maybe for a few months or maybe a year, depends, okay? So we'll monitor your levels, how are your levels doing, and then we'll stop if the remaining gland has compensated. Any questions? Okay. Remember I said earlier that the problem can either be one or both adrenal glands. Okay, what if it's both adrenal glands that have the pheochromocytoma? You're just very lucky, okay, that you have two of them. So now you will lose both adrenal glands. So now, do you have any hormones left? No more endogenous hormone production. So now what will you end up doing? You have to take the hormones forever, for life. How much the doctor will determine depending on your needs. However, will your needs be static? Will it stay the same? Let's say today you have no exam. Next week you have an exam. So will your hormone needs be the same?
No.
No. So we'll have to do teaching for the patient, meaning if this patient has some stressful events, let's say they're getting married, getting divorced, okay, getting pregnant, or losing the babies, some stressful event, including, happy times. Let's say you won the lottery. I was really stressed. Okay, I don't know how to spend this money. It's $1 billion. So that is also stressful. So you make adjustments on your doses, okay, under physician supervision, of course. Here's a complication during the tumor, during surgery. This can occur. We didn't intend it because what will happen whenever you undergo surgery? Is that a stressful event? Yes. So during a stressful event, what happens to your epinephrine or epinephrine? Okay, suddenly does that. So therefore, this could occur during surgery. So we just watch for because remember the adrenal gland doesn't have to produce it constantly when it's needed, meaning we already have it stored, okay, meaning we already produced it but we didn't release it, okay. The adrenal glands, just we didn't release it because we didn't need it yet, but when you need it, it will be released right away, which is what happens or what could happen during surgery. Okay, we'll discuss the dosing under the next topic. All right. Now remember, the Adrenal glands are only controlled by the pituitary gland, correct? So I mentioned earlier, if it's a pituitary disorder, could you have adrenal problems?
Yeah.
Yes. Okay. So there are times wherein yes, in pheochromocytoma, where is the tumor? In the it's in the adrenal gland. However, you could also have conditions wherein the tumor is in the pituitary gland. Now it will depend. What did that tumor do? Did the tumor cause an increase in hormone production, or did it cause a decrease in hormone production? Either way, what will we do with the pituitary gland? There's a tumor on it. We're gonna have to remove the pituitary gland along with the tumor. Because how big is the pituitary gland? A pea size, right? So therefore, which one will be bigger? The tumor or the gland? The tumor. So can you excise the tumor off of that little pea-sized gland? No. So you will lose the pituitary gland. And as a result, will it be the same? Like taking out your adrenal gland? Basically, yeah. Okay, because without the pituitary gland, can your adrenal glands do anything? Not without the pituitary gland. The pituitary gland controls the adrenal gland. So as a result, the adrenal glands become useless. Okay, so now will you require hormone replacement? For how long? Lifelong as well. Make sense? Okay, so we'll take care of the post-op care for the pituitary gland later because it's in a separate chapter. Let's start with Addison's disease. Now, Addison's disease is also called adrenocortical insufficiency, meaning this is a deficiency in your salt and sugar hormones. This problem only affects, there's two possible causes here. Either it's a pituitary gland hypothalamus problem, or this could also be an adrenal cortex problem. Okay, so either way, you have adrenal insufficiency, meaning not enough salt and sugar hormones. Let's review. What's the purpose again of your salt and sugar hormones? Salt hormone is responsible for, no, aldosterone. Aldosterone is responsible for blood pressure, right? Blood pressure, raising blood pressure, and raising sodium levels, correct? And therefore, if you don't have enough aldosterone, what happens to your blood pressure? Low. What happens to your sodium levels? Low. What happens to your potassium levels? High. All right, very good. Now let's go to the cortisol. Your cortisol levels are low. What happens to your blood sugar? Low. What happens to your blood pressure? Also low. Okay. So therefore, in this condition, what are the three problems we will anticipate? Blood pressure will be, sugar will be, potassium will be. Very good. Okay. So every day, those are the three problems these patients will be facing with. So treatment, of course, will have to be targeted to those three problems. We're going to have to take medications to raise blood pressure, raise sodium, and lower potassium. Okay. There's some drugs can affect or cause this problem as well. So these are the drugs known to cause adrenal insufficiency as well. However, this will be, if it's drug induced, it's temporary though, meaning it's only occurring because you're taking these medications. Then of course, if we take it out, then you're back to normal. Does that make sense? Okay. Another cause of adrenal insufficiency is, remember when we learned about steroids? What did your farm teacher say? When we stop taking steroids, how should we do it? We taper it off. Why? So when we're taking steroids, what's happening to our body? I'm taking steroids. So I know what you're trying to say, but that's not the correct word.
Is it because it's
So what
taking
happens to
out-
the adrenal function? You're taking steroids by mouth.
It drops too low, you gotta take it off, so it could ease off, it's like when
You
you.
mean its activity is suppressed, right?
Yeah.
Okay, so meaning the adrenal cortex doesn't feel the need to release any cortisol. Why? Because you're taking it. Okay, you're taking it, you're taking the steroid, the glucocorticoid. So therefore, of course, the adrenal cortex will say, I don't need to make any because it's already high. The levels are high. Okay, so I'm not doing anything. Okay, so the adrenal cortex will just do this. Okay, and then some bubble tea here. Okay, it will just relax. Okay, we won't do anything because it doesn't have to. You're taking the steroids exogenously. You're taking it in pill form or IV form. So what did the farm teacher say? When we stop this, it should be gradual, right? It should be tapered. That way, the adrenal gland, the adrenal cortex, right, has an opportunity to increase its activity. Okay, to adjust. Right, very good. Now, did they tell you what could happen if you stop it right away? Okay, this is what's gonna happen. Okay, so the patient will have adrenal insufficiency. How bad? Well, depends. How much steroid were we talking about? Okay, right. How much? Well, which is the same as with how long you've been taking it. So you could die literally. Okay, so that's another reason why we taper it. Okay, so you don't die from hypotension, which is shock, right? And then hyperkalemia and hypoglycemia. So if you do that, let's say you've been on steroids for 6 months, then you stop it. I'm tired of taking it. No more. I stopped taking it today. Or let's say you didn't intend to do that. You just got sick. You've been on steroids for 6 months, and then all of a sudden, it was domestic violence. You were beaten up, and then now you're unconscious. And the doctors don't know your history. They don't have a list of your medications. They don't know you were taking steroids. Okay, and then you're unconscious, you're intubated. Now what could happen? You will die from what are the three things you can die from? Shock. Yeah, low blood pressure shock, hypoglycemia, and hyperkalemia. Okay, you'll die from those three. Okay. So is it important to educate people on steroids? Yes, it's okay to scare them a little bit. Okay, so tell them about adrenal insufficiency. Okay, no, I'm serious. This is serious. Yeah, this is big deal. Yeah. Okay. So manifestations, of course, will be manifestations of hypotension, hyperkalemia, and hypoglycemia. Okay, so you'll see that here. If you look at this here, hypoglycemia causes lethargy. Yeah, muscle weakness, and then because of your low blood pressure, low sodium, then you'll have some weight loss and nausea, vomiting from hypokalemia and hyponatremia and hyperkalemia. Hyperkalemia can cause nausea, vomiting as well, and diarrhea. So the severe form of adrenal insufficiency is called Addisonian crisis. So one reason is, again, you suddenly stopped steroids. Okay, stop taking your oral steroids. Okay, suddenly you stopped it. That can cause a Addisonian crisis. Or it could also be someone with adrenal insufficiency, which means, the person with Addison's disease had the disorder under control, meaning they're taking the hormones regularly as prescribed, but then they suffered an event. What is that event? It could be surgery. It could also be any stress. Okay, stress is very subjective, yeah? Some stressful event or trauma. So infection also. Is infection stressful? Yes. So you develop an infection, surgery, trauma, or any emotional event. Okay, because what happened to your hormone needs during those instances that I mentioned? Surgery, trauma, infection. What happened to your hormone needs? they increase, but then was there enough? No, because let's say you did not change your dosing, right? So that can all lead to Addisonian crisis. So Addisonian crisis is a severe state of hypotension, hypoglycemia, and hyperkalemia. Okay, altogether, that's called Addisonian crisis. And these are your manifestations: severe hypotension, cyanosis. Okay, so again, all caused by hypotension, hyperkalemia, and hypoglycemia. Other manifestations here, we have a I know, I'll discuss that later. So again, what are the main problems of the patient? Day to day? Okay. So if it's just Addison's disease, meaning not not an Addisonian crisis, you'll have the same problems, but at a manageable level. Okay? Not really severe. If it's Addisonian crisis, like really severe, severe hypotension, severe hypoglycemia, severe hyperkalemia. Management. Depends. What are we treating? Are we treating Addisonian crisis or Addison's disease? If it's Addison's disease, it's just maintenance of your hormone intake. So you'll be given steroids, either hydrocortisone, which is Solucortef, or it could also be prednisone. Okay, but most people are on hydrocortisone. The beauty about hydrocortisone is at higher levels, it doesn't just do it just doesn't have it does not only have glucocorticoid effects but also mineralocorticoid effects, meaning you don't have to take multiple drugs. Hydrocortisone again at high levels serves to do the aldosterone as well as the cortisol function. Okay, just one drug. Okay, at high doses. So we'll do the same here. If the patient is in Addisonian crisis, so of course we're gonna have to treat it aggressively, correct? So can we give fluids? Yes, lots of fluids. The fluid here will be isotonic. However, can we use dextrose?
Yeah.
Yes, that's even better, right? Because now you have D5W is still isotonic, correct? Then you address both at the same time. You're addressing blood pressure and you're also addressing hypoglycemia at the same time. And you still remember interventions to lower potassium? Okay, regular insulin with dextrose, calcium gluconate or calcium chloride. Yeah, the albuterol, yeah, sodium bicarbonate, and what was the oral or rectal? Patiромir or sodium polystyrene sulfonate, SPS. Very good. So we'll give all those IV, all right, to manage the three problems. So obviously, can you choose one to administer over the other? Because can you put um emphasis on which one is less worse? Hypotension, hypoglycemia, or hyperkalemia? Can you prioritize? No, each one can kill by itself. So therefore, can one nurse address this patient? No, if it's Addisonian crisis, where is this patient? In ICU. A team will be addressing this patient. Okay, so several nurses will be caring for this. A doctor will be directing care. If the patient, of course, we discussed shock already, vasopressors may be given if we cannot raise blood pressure with hydrocortisone only or with fluids only. Okay, so hydrocortisone with fluids will be have to be given. Okay, in order to raise the blood pressure. Sometimes we can even do hydrocortisone infusion. Okay, it'll be a continuous infusion. Plus, regular twice a day, maybe either IM, okay, as IM will last longer than IV. Antibiotics if the patient's cause of Addisonian crisis is an infection. All right. But otherwise, if it's, other things, then of course, no antibiotics needed. If the patient's awake already, because you think the patient's awake with hypotension, severe hypotension, severe hypoglycemia, severe hyperkalemia, no, probably out. Yeah. But when they're awake, of course, we can give them things by mouth now. So assessing, again, all those three problems. The patient will have some sexual characteristic changes, but obviously that's not really important during the emergent period, right? So what will address that? With hormone therapy, then that will, of course, subside the patient's symptoms, okay? Because the patient will have the female patient, okay? So we'll have some amenorrhea, other, they'll have less, they'll feel less of a woman, okay? So we discussed fluids and then steroids, okay, to maintain blood pressure. Oxygen as needed, of course, because of the hypotension. And then once we send them home, we teach them the following. Okay, so to never stop the steroids. What if they get sick? They can't keep anything by mouth. What are they instructed to do? Okay, yeah, go to the ER for injection of the steroids instead of by mouth. Or if someone at home knows how to give an injection, then they'll be prescribed IM, okay? IM hydrocortisone can be given. So they need to know the signs and symptoms when to call, okay? So, severe. Yeah, so just like people, giving, GLP-1, yeah, Ozempic, you can, do self-injections. We just need to teach you. All right. Any questions on Addison's disease? Okay, last topic. I think my battery can hold on. Okay, I still have 17%. Okay. So let's say this patient has been on steroids, right? Forever. Do we know if the steroids will be the same all throughout their life? The dose will be exactly. No, it's gonna change, right? Could their hormone requirements increase, during stressful situations? Yes. Could it also decrease? Yes, because of this, unpredictability, can the patient end up with too little? Can they go into Addisonian crisis? Yes. Can they also have too much? When it's too much, we call it Cushing syndrome. Okay. So the patient, obviously, with Cushing syndrome is any patient who's been taking any steroids for a long time, just like the Addison's disease patient, and then they ended up too much of the hormone, they'll develop Cushing syndrome. Cushing syndrome now is different. It's now the opposite. Now they have too much, yes, too much salt hormone, too much sugar hormone now. So we do the opposite. Now their blood pressure will be very high. Their sodium levels will be very high. Sugar will be high. And potassium will be low. In this chapter, though, because theoretically, potassium will be low, correct? If your aldosterone is high, that means sodium's high, potassium is low. In the chapter, though, they won't mention it. But theoretically, will it be low? Yes, theoretically, okay? Since the author did not mention it in this section of the chapter, they don't mention hypokalemia. So I would guess that maybe the hypokalemia is not going to be severe. Does that make sense? Because they didn't address it. But theoretically, should it be low? Correct. So this is Cushing syndrome. Okay, so a condition wherein a patient ended up with too much hormone therapy through no fault of their own. As a result, so the three conditions we mentioned earlier, and then these are now the manifestations. There's a picture here. There. That's what a patient would look like. We don't have the whole body, but believe it or not, this is a woman. This is a female patient. All right, so this is what we mean by correct. Yeah, the moon phase, and then we don't see there's a buffalo hump. Okay, so there's a big camel hump right here in the right, and then the rest of the body they'll have abdominal obesity, and then there'll be edema in the legs as well. Okay, and the skin we don't have the abdominal picture, but the abdomen is so stretched that there will be some striae, some stretch marks. Okay, a lot of stretch
Like
marks.
she have men's organs.
The what?
She is
No, it's not like what were you saying?
finished.
Oh yes, yes, of course, yeah. The patient. This is what you were asking earlier that they have a yeah. But of course, doesn't mean I'm not saying those people have Cushing syndrome. Okay, so maybe they do have some hormone imbalances, so that's why they grow beard, all right, some facial hair. And some okay, you reach a certain age wherein if you were younger, maybe you'll care, you'll pull them or maybe shave. But some ladies I know, it's reached a certain point wherein they just what for? They're not looking for a mate. They're already married.
So, Professor,
Just let go. Yeah.
those later,
I'm sorry.
how would you take it out? Step by step?
Yes, this is gradual. Yeah, yeah. But when I say gradual, though, we're talking months, though, not years. So in a few months, right? So that's why the stretch marks appear because the abdominal stretching, the abdominal obesity occurs in such a short time. Okay, unlike when you become obese because of eating, it's not gonna happen in a few months. It's gonna be like years, right? When you see really huge people outside, like they didn't get like that in a few months. Okay, it took like years. Yeah, they had invested in a lot of Doritos, to get to that point, right? So this one though occurred in a matter of months though. So the skin wasn't able to adjust to the enlargement. Okay, so that's why there's stretching, and then the skin will be prone to injury. And here are your complications. There's heart failure, hypertension, there's you start growing pimples again. Okay, so the stretch marks, thinning of the skin. Here, so these are the problems. All right. Peptic ulcers because this is a stress hormone, right? Your cortisol is high, so therefore acid production is also high. So you have peptic ulcers as a result. Impaired wound healing, okay, meaning if these patients have to go to surgery, then that could be a problem, okay, because their hormone levels, stress hormones are so high, so there's immunosuppression, yeah, and then that will cause impaired wound healing, and then susceptibility to infection is also increased. It can hold cataracts, glaucoma. There'll be mood disorders as well. Okay, mood changes. Osteoporosis will go because now they have abdominal obesity, so that means they can have back pain. Okay, there'll be a muscle wasting as well because now there's more fat than muscle. Okay, and that could predispose them to compression fractures as well. So testing, we of course look at your hormone levels, your stress hormone levels, as well as aldosterone. I have no question on the testing. The doctor will do that. We have really no role in it. Management. Since this is Cushing syndrome, was there a reason why you were taking the hormones in the first place?
Yeah.
Yes, unfortunately. Okay, there was a reason why the doctor put you on steroids. So can we stop the steroids? What was the cause of Cushing syndrome again? You took too much. So what can we do? Okay, we'll have to adjust the dose. Okay, so we'll look at your hormone levels. Obviously, you don't need this much, so we'll adjust the dosing. That's all we can do. So the patient's manifestations will just go to some maybe acceptable level. It's not gonna be go back to how you guys look. Yeah. So how you look now. Yeah, forget about it. Okay, meaning yes, you'll be at an acceptable level. Okay, but it will never go because remember you were taking the steroids for something. Okay, we can't stop it. We can't eliminate the reason why you were put on steroid in the first place. You need the steroids. but you ended up with too much. So all we can do is adjust the dose. Okay. Again, it's hard. It's easier, to discuss it, but because your hormone needs change constantly. Okay, when you're under stress, you need more. When you're relaxed, you don't need much. But can you predict that? I mean, no. Correct. Plus, this is exogenous. Okay, this is not your own steroid. You're taking it, by mouth, right? Yeah, we there's really no, the treatment the patient has to be realistic with the outcome. Okay, so don't expect perfect like when you were a teenager. Okay, no more. Okay, that's gone. Okay, those days are gone.
So does it depend on the lab results?
Again, yeah, lab results. Yeah,
So if it's no
your
need,
hormone levels. Okay.
so if it's no need, you stop it.
Yes, again, what was the reason why these patients were on steroids in the first place? It depends. If we can afford to stop it, yeah, of course, why not? But most of the patients that are on steroids are on it for some chronic reason, some permanent reason. Okay. Let's say, they receive an organ transplant. Yeah, have to be lifetime. Or you have Addison's disease, that's lifetime. Yeah. You understand? Okay. However, there's another form of Cushing's, which is now Cushing's disease. Cushing's disease is if it's an adrenal cortex tumor, or if you have an adrenal pituitary adenoma. Okay, so either the tumor is on the adrenal gland, cortex, or in the pituitary gland, causing a high level of aldosterone and cortisol. Okay, meaning it's not because you were taking, you see the difference? It's Cushing syndrome if you're taking hormone pills, steroid hormone pills, which cause the Cushing symptoms. But it could also be a disease, usually a tumor, okay? A tumor in the pituitary gland or in the adrenal cortex that's causing the increased production. So the difference between the two is, where did the increased hormone come from? Did it come from a pill bottle? We will call it Cushing's syndrome, correct? If it's from tablets, but we'll call it Cushing's disease if the hormones came from your own body. Does that make sense? Because is the treatment the same? No. With Cushing's disease, what is the treatment? Because it's caused by a tumor. So surgical removal of the pituitary tumor or surgical removal of the adrenal gland. So we already discussed adrenalectomy earlier. Now let's discuss hypophysectomy. So yes, hypophysectomy. That's the surgical removal of the pituitary gland. Let me go to the page. Now, where is the pituitary gland? Pituitary gland. Where's your pituitary gland? It's in your brain. It's between your eyeballs. Okay? It's right here in the center. Okay. All right. So the treatment of choice, the surgical removal approach of the pituitary gland is through the nose. That's the easiest way to do it. Because it's a hassle if we have to go through your skull. Okay, it's a lot of work, and plus there's a long recovery. If we go through your nose, it's faster. So the approaches will be transsphenoidal hypophysectomy. So we need to know the pre and post-op. So let's go to Okay, I can't find it, but please search on your own. But let me just discuss. It's through the nose. So is it brain surgery still? Yes, you just went through the nose, but it's still brain surgery. So do you need to monitor neurologic status afterwards? Yes, please. So when we put instruments through the nose and also at the roof of your mouth, so another incision will be made at the roof of your mouth to put more instruments through. Okay, because we can't just do it through the nostrils. We have to go through the roof of the mouth as well. And we have to remove the sphenoid bone. That's a bone that separates your skull from your facial cavity. Okay, so we remove the sphenoid bone to get the instruments through, and then we'll remove the pituitary gland and the tumor through your nose. So post-op, you had brain surgery through your nose. Will there be bleeding? Yes, there'll be bleeding. So tell the patient, okay, your nose will be plugged, okay? We'll put some packing in your nose to catch drainage. And there'll be also a mustache dressing, a dressing over here. And then we'll remove the mustache dressing if it gets soaked. No, we'll replace it as it gets soaked. We'll change it again. So since there's an incision in the roof of the mouth, can they brush their teeth? No, you don't want to hit it with the toothbrush. So they'll be just told to how to clean my mouth. Rinses only. Okay, so no mild antiseptic mouthwash. Okay, nothing with alcohol, of course, that will sting. Okay, so non-alcohol antiseptic mouthwash. Okay, you can floss, nothing wrong with flossing, but no toothbrush. Okay, even if it's soft bristled toothbrush, the stick itself is hard, correct? So no toothbrush. You can floss. You can do antiseptic mouth rinse. No coughing, no sneezing, no bending down. Remember the post cataract surgery um restrictions we discussed last semester? So same thing, okay? So no bending down, okay? No sexual activity because sexual activity causes pushing and pulling, right? So no pushing and pulling, meaning no activity that will cause you to hold your breath, okay? Because when you sneeze, you have to hold your breath, right? Coughing, same thing. Yeah, so constipation also. So no pushing to, right. Yeah, heavy lifting also, nothing. Okay, so basically anything that will involve pushing and pulling, okay, or holding your breath, because that will increase intracranial pressure. There will be also a possibility of a CSF leak through the incision. So we test the drainage. The drainage won't be clear because it'll be mixed with blood. Okay. So the drainage is bloody, but so we can't tell them apart whether it's yellow because CSF is yellow, correct? Clear yellow, and then it's already mixed with blood. And since blood contains sugar, we can't use glucose testing to check for CSF. Okay, because blood always has sugar. Okay, and the only way we can tell CSF from blood is the sugar. But since the drainage is bloody, it's all mixed together. So what we'll do is, remember the halo sign? Okay, when you get a piece of gauze, you dab the drainage. If the drainage has a yellow ring around it, that's CSF. Okay, we call that the halo sign. Okay, that's about it. Of course, the patient now lost the pituitary gland, or let's say they lost two adrenal glands. So now what do they have? Addison's disease, right? So now they have adrenal insufficiency, correct? And then how did we treat adrenal insufficiency? Lifelong hormone replacement. Can they have Cushing syndrome? Yes. Yeah. So you have to explain this to the patient who has Cushing's disease. So you go, Miss Nolasco, you have Cushing's disease. Okay, that's why you look like this. Okay, so let's say you saw the picture, right? So they have the moon face, the buffalo hump, abdominal obesity. Okay, what are my choices? Okay, this is what we're gonna do. We're gonna do either hypophysectomy or adrenalectomy, right? Okay, let's say she had bilateral adrenalectomy. And then what? Am I gonna be cured? Yes, you no longer have Cushing's disease. However, because you lost these hormones, you're gonna have to give you hormones for life, and you may develop Cushing syndrome. What is that? Same thing as you had before. You understand? So the patient basically has with Cushing's disease. I'm not saying that's gonna happen, okay, but it could, right? They could go from Cushing's disease to now Cushing syndrome. It's unfortunate. That's what's gonna happen.